Now we're going to discuss surgical procedures for heart failure. One of those being the primary treatment for anyone with end-stage heart failure is a heart transplant. The downfall to heart transplant is it's very beneficial, but it's limited to the availability of donor hearts. So you have to have a deceased donor in order to have a heart transplant. Some things that you have to worry about with patients that have had a heart transplant are the risks of infection and rejection. So, in order to prevent these patients from having rejection, they get put on immunosuppressant drugs that put them at an increased risk of infection. So, these are patients that need to make sure that they get their influenza vaccine and their pneumococcal vaccine every year. While they're waiting to have surgery, kind of like a bridge between heart failure and transplant is a ventricular access device, and that's used for patients that have severe heart failure. And it basically is a pump that is mechanical and it requires an external power source, but it's connected to the diseased ventricle and it actually reduces the workload of the ventricle and helps maintain cardiac output. It's usually left ventricle, but it can be right or it can be biventricular, which means both ventricles. And it's portable and the patient can use it at home. And the other surgery is called dynamic cardiomyoplasty, and that's where they actually will take some skeletal muscle and graft it around the heart so that it supports the entire myocardial muscle. And it's not really successful. This slide is just a mnemonic for treatment for congestive heart failure, and it's unload fast. So you sit upright, nitro, Lasix, oxygen, aminophylline, but you can also substitute ARBs or ACE inhibitors, digoxin, fluids that we decrease, afterload decrease, sodium decreased, and then tests. So if our patient is on digoxin, they have to have that digoxin level. ABGs, potassium. If they're on diuretics, they can go up if it's a potassium sparing diuretic, or they'll have hypokalemia if they're on loop diuretics. Our priority for nursing care is to reduce oxygen demand and the workload of the heart. So as the heart becomes less effective as it pumps, the patient will have more difficulty with gas exchange. They'll be more fatigued, more tired, and the heart will have to work much harder. So our goal is that we will provide rest periods for our patient in between procedures, make sure that they're on bed rest to decrease that workload of the heart. For health promotion, we need to make sure that we educate our patients on coronary heart disease because that is the main cause of heart failure. So patients need to know about risk factors, lifestyle, making sure that they manage their hypertension, diabetes, they have a healthy weight, they're eating a heart healthy diet, that they don't start smoking, and if they do smoke, they attend smoking cessation classes and do their best to stop. Patients that already have heart failure, we need to again make sure that they do whatever they can to maintain their cardiac reserve, prevent whatever exacerbations we can. They should follow that low sodium diet, make sure they avoid any exposure to any infectious illnesses, and make sure that they get their flu shot and pneumococcal shots yearly. Well, pneumococcal not yearly, but flu shot yearly. Assessment we're going to talk about on the next slide. So this is a really nice box that shows both subjective and objective data that we should be gathering on our patients. So let's start with subjective. These are the things that the patient that has congestive heart failure is going to tell us. So they're going to complain of shortness of breath, Their level of activity is going to be decreased. They're not going to be able to do as much as they used to be. They're going to say they have to put pillows underneath them to be able to sleep, or they're sleeping in a recliner. They're going to complain of swelling in their legs and feet, and also probably some abdominal discomfort, because remember, they have that ascites, which is edema in the abdominal cavity. They may have weight gain, and then they also might complain of a decreased appetite and nausea. For a history, do they have a history of an MI or other heart disease, some kind of new stress in their life? And that can be a medical stress, something like a respiratory infection, which can actually increase the workload of the heart. And what medicine have they or treatments have they tried for heart failure, and what are their current medications? What are their risk factors? Do they have a family history of heart disease? Do they have hypertension, diabetes, hyperlipidemia, smoke? Do they smoke, and do they drink alcohol? Do they understand what heart failure is, and do they understand what their treatment is? They may not even know what foods have sodium in them. Are they compliant with whatever activity their provider has prescribed? And then for objective data, our vital signs. We're going to look for heart rate, blood pressure, right? Because we know hypertension causes an increased workload on the heart. Do those vital signs change with activity? What is their respiratory rate? Do they have any arrhythmias? Are they short of breath? And if they're short of breath, is it at rest or is it with activity? What is their pulse ox? Do they require oxygen? What's their skin color? Do they have any cyanosis or pallor? Is their skin warm or dry? Is it hot or cool? What's their capillary refill? And if they have edema, where is it located and how significant is it? What is the degree of edema? Make sure you're looking in the sacral area, because remember, these patients have dependent edema. Do they have neck vein distension? And then you're going to listen to their heart and lungs. They may have extra heart sounds. And then when you listen to the lungs, you're going to want to listen for crackles. That indicates fluid in the lungs. And do they have any wheezing? You're going to keep strict eyes and nose on these patients and do a daily weight. We want to make sure they're urinating, okay, because we don't want that intake to be greater than their output. Level of consciousness. Are they anxious? Are they fearful? Hemodynamic parameters. Those are going to be monitored if they're in an intensive care unit, and that's measuring the pulmonary artery pressure and cardiac output. And then what are their lab tests? The BNP, remember, if it's greater than 100, that indicates heart failure, and the higher the level, the worse the heart failure is. Serum electrolytes, we're going to pay attention to sodium and potassium. Remember, if they're on diuretics, if it's a loop diuretic, they'll lose potassium. If it's potassium sparing diuretic, their potassium will be high. And then also their ABGs. And then if they're on digoxin, make sure that you're looking for the result of that dig level. More nursing care. We have potential complications that can happen. So acute pulmonary edema. Remember, these are the patients that are going to have fluid in the lungs. They're going to have frothy, blood-tinged sputum. They're going to feel like they're drowning. And that is a medical emergency. Liver and kidney failure. Remember, with right-sided heart failure, there is a backup, so they can have hepatomegaly, and the kidneys can fail because there's decreased perfusion to the kidneys. And then they may also have mental status changes. For diagnosing, planning, and implementation, that can be found in your textbook on page 412. So one of the diagnoses we would use would be decreased cardiac output, right? That's the whole point of what heart failure is. Their heart's not pumping to the extent that it should. You're going to pay close attention to heart and lung sounds, report any decreased cardiac output symptoms. administer oxygen as ordered, medications as ordered, encourage rest, making sure head of bed is up, um, make sure they have a bedside commode, and assist them with any personal hygiene. For excess fluid, if the patient develops air hunger or a sense of impending doom, panic, tachypnea, orthopnea, cough that's productive with that pink frothy sputum, you know that's a sign of pulmonary edema, acute pulmonary edema. You need to notify the provider right away. We're going to monitor those eyes and O's, daily weights. Remember, same time, same place, same clothes. They're going to be in Fowler or high Fowler's position. You're going to report any vital sign changes or newly distended neck veins, change in their peripheral edema, weight gain, worsening dyspnea, and any dysrhythmias. And then activity intolerance. You're going to make sure that you're monitoring vital signs before and after. You're going to provide rest periods in between activities. And you're going to plan a progressive activity plan for these patients. They're going to have active and passive range of movement, especially if they're on bed rest. Okay, as they progress and start to feel better, you want to make sure that you're gradually increasing those activity levels. And you're going to encourage small, frequent meals instead of those 3 big meals in the day. It's much easier to eat. It causes less work on the heart, and they're able to digest food better. Okay, and that is the end of our lecture on heart failure. Just wanted to do a brief summary. Heart failure is when the heart is ineffective at meeting the oxygen and fuel demands of the body. The pumping action is not what it should be. Left ventricular heart failure, the heart is unable to pump blood into the systemic circulation, causing a backup into the pulmonary circuit. So their symptoms are going to be short of breath, have dyspnea on exertion. They may have fatigue, they'll experience orthopnea, tachycardia, and they'll have crackles, and they can end up with acute pulmonary edema. So they can have that pink frothy sputum, feel like they're drowning. Right ventricular heart failure is when the heart's unable to pump blood into the pulmonary circulation, and that causes a backup into the venous circulation. So those are your systemic problems. So those symptoms are jugular vein distension, fatigue, ascites, weight gain, dependent edema. Some testing that we'll do on these patients, diagnostic, that BNP, which is the hormone above 100, and the higher it gets, the worse the heart failure is. Ultrasound, less than 40% is concerning for heart failure, and that measures the ejection fraction of the left ventricle. And then chest x-ray will show cardiomegaly. And then if they're in intensive care, it would be hemodynamic monitoring. Our nursing priorities are to optimize activity and tolerance, manage their fluid volume, and promote gas exchange. We want that heart to work at its full capacity. And then our management is to monitor labs, assess fluid status, give medication as prescribed, correct electrolyte imbalances, conserve energy, and promote health and wellness. Medications, ACE inhibitors, vasodilators, diuretics, electrolyte replacement if needed, inotropic meds, ARBs. Next, we're going to go into inflammatory cardiac disorders.